Hello and welcome to my educational review of Respiratory System Part 1. So I'm going to start out with discussing obstructive lung disease versus restrictive lung disease. So we always talk about FEV1 and FVC. Well, actually both are decreased in both types of lung disease. It's just that the magnitude of the FEV1 decrease is greater in obstructive. So the ratio is going to be much less in obstructive than it is restrictive. In obstructive, it's about 50%, and restrictive, it's close to 80% or close to a normal 1 ratio. When we talk about obstructive diseases, we include asthma and COPD. Restrictive diseases are usually named for etiology, sarcoidosis, asbestosis, pneumoconiosis. Remember that cancers can show symptoms of both. Emphysema, I just want to discuss emphysema because the DLCO is going to be decreased in emphysema just like it is in restrictive lung disease. However, the two are very different. Emphysema has an obstructive pattern, whereas restrictive lung diseases have the restrictive pattern. Emphysema also causes an increase in all lung volumes, so because it increases the compliance. But remember that the DLCO is decreased because of the alveolar damage that it wreaks. Some important associations. If you have a patient with emphysema and liver disease, you think alpha antitrypsin deficiency. If you have a brake liner, factory worker, you think asbestosis. And there are two cancers that you want to associate with asbestosis, bronchogenic and mesothelioma. Now, if you want to know which one you're going to most commonly find in a patient who has asbestosis, it's going to be bronchogenic carcinoma, just because it's a more common disease, more likelihood. Mesothelioma has a stronger association, however, with asbestosis. Small cell carcinoma, associated with SIADH, and squamous cell carcinoma can lead to hypercalcemia. Also, if you think of a sandblaster, you would associate that with silicosis, and silicosis affects the upper lobes, in contrast to asbestosis, which affects the lower lobes. Asthma is not always diagnosed at rest, so you could be having the wheezing, the shortness of breath, and go to the doctor's office a few days later, and your function tests are going to appear normal. So the doctor usually gives a methylcholine challenge test or has you go and walk outside, and it's confirmed. A presentation of asthma is atypical asthma, which you might just present with a cough and not have the classic symptoms. The treatment of asthma. So cardinal rule for the treatment of asthma is you never want to prescribe long-acting inhaled beta agonists alone. So you always want to prescribe a long-acting beta agonist with an inhaled corticosteroid. So as for how you prescribe, so you always start with a short-acting beta agonist for use as needed in mild intermittent asthma. So when the patient starts to have symptoms, they'll start using the inhaler. Now, if they start to have nighttime symptoms or if they have an increased frequency of symptoms above intermittent, then you add the inhaled steroid. If there's increase in the nighttime symptom frequency and or they have hospitalizations, then you would add the long-acting beta agonist. There are other drugs like leukotriene inhibitors or oral steroids that can be also added onto the severe regimen. Last but not least, I'm going to discuss the treatment of COPD. When we treat COPD, we want to target airway inflammation and bronchospasm. So tiotropium, ipratropium are first line. And two things can decrease mortality: home oxygen with a PaO2 of less than 55 or oxygen saturation less than 88%, and also smoking cessation in a smoker. So that ends the first part of my discussion on the respiratory system. Please like my video if you do, and also subscribe.